everyone. Welcome to Preemie Chats. It's great to have you joining us here today. Preemie Chats is a program that is created by and put on by Canadian Premature Babies Foundation. It's for healthcare professionals and parents to talk about what matters to you, to explore new ideas together, and to learn. I'm Leah Whitehead. I'm the mom of a preemie and a former journalist, and I'm happy to be your host today from Halifax, Nova Scotia. As I mentioned, Preemie Chats is put on by the Canadian Premature Babies Foundation, and you may also know them as CPBF. The foundation is a parent-led charitable organization that helps families in and after NICU through education, support, and advocacy. And I'd encourage you, if you have a heart for preemies, whether you're a family or a healthcare professional, head over to their website, canadianpreemies.org. It's got some new content up there. You will find many resources that are all free, the latest projects Canadian Premature Babies Foundation is working on, and most importantly, a community of people who want to see our little ones thrive. Today's session is live, so I hope that you will bring your voice to the table today. Leave comments and questions in the chat, and we'll try to address them during our program. It is through rich conversations like these where we advance practice and learn together. So please participate and also let us know where you're watching from. It's always interesting to know who is watching from where in our audience. On to today's topic. This is one that so many preemie parents ask themselves after NICU. Is my preemie child eating and growing well? All families can attest to one of the challenges in NICU is feeding, whether it's tube feeding, bottle feeding, breast or chest feeding. NICU parents are always talking about how much their babies are eating and how much they weigh. And sometimes those challenges don't just go away after a NICU stay. Many toddlers and children who are born preterm have different obstacles when it comes to feeding and growth, and it's not unusual for these little ones to get the label picky eater. Well, today we're going to talk about what that can look like and when families should be concerned. I'm pleased today to be joined by Thuy Mai Luu, a pediatrician, the medical director at CHU Sainte-Justine Neonatal Follow-Up Program, and associate clinical professor of pediatrics at Université de Montréal. She researches long-term neurodevelopmental and physical health outcomes following preterm birth from infancy to adulthood, looking at risk and resiliency factors, along with best screening strategies to enhance clinical follow-up. She is also the director of the Canadian Neonatal Follow-Up Network, and that's a research network that includes 26 neonatal follow-up programs across Canada. Welcome, Thuy Mai. Thanks for joining us.
Thank you so much for this introduction. So it's always a pleasure to be presenting at the Preemie Chat. And this topic actually was suggested to me by Fabiana as a topic which was of interest to the Canadian Premature Babies Foundation. And I guess we all have our experience with the food. It's supposed to be something fun, which is, should bring pleasure. But we also know that for children born preterm, sometimes that comes with some challenges. So, oh yes. So today's presentation, I'll focus on two things. So I think the main question that I see in clinic is there's a lot of variation of normal. So I guess what parents want to know is my child doing okay? So first, I'll be talking about expected growth in infants and children. I'll talk about general concepts and also focus on what may be specific to premature babies. And the second part of my talk will be about the picky eater. Next slide. So basic things to remember. So first of all, for infants born preterm, it's really important to use corrected age up until 24 to 36 months. And sometimes I do see some healthcare professionals in the community which are concerned because the child is under the curve, but they actually forgot to correct for prematurity. And just as a reminder, but you probably already know that, corrected age is the age of the infant from birth minus the number of weeks of prematurity. So for example, and I'll use this example throughout my presentation, if we have a baby born at 28 weeks, that means it's 12 weeks of prematurity. So that's equivalent of 3 months. So at 4 months of life, that would be equal to 1 month of corrected age. Next slide. So let's say we have baby Tom here who's born at 28 weeks. If we look at 4 months of chronological age, Tom weighs 4 kilos. So if we look at the curve, the round dot, we could see that, wow, Tom is below the curve, and this is of concern. And actually, like, some people might be worried and start doing investigation or starting some care management, which actually would not be appropriate if they would actually take into account the 3 months of prematurity. So if we look at corrected age, and this is the triangle, we can see that Tom is actually fine and is within the normal range. Next slide. And we can see that usually what we are supposed to do is really to plot both chronological age and corrected age up until 24 to 48 up until 24 to 36 months, just to see how the baby is growing. And we can see here that when we get to 24 months of chronological age or 21 months of corrected age, the difference in terms of where the child is located on the curve is not as important as whereas when the child was 4 months of chronological age versus 1 month of corrected age, we can see that this correction makes a big difference. So that's a little bit the rationale for why we make the correction up until 2 or 3 years. The difference between a 21 and a 24-month-old baby is not as large as a baby who's 1 versus 4 months of age. Next slide. The other thing to remember is if the weight for corrected age is under the curve, is this of concern? And I also see that very often. The parents will be like, wow, even if I account for prematurity, my child is under the 3rd percentile. So first, let's just look where those curves come from. Next slide. So those curves that we use in Canada are based on the World Health Organization. And this was from the Multi-Center Growth Reference Study, which recruited babies all across the world from 6 specific countries in Brazil, Ghana, India, Norway, Oman, and the USA. These children were born at term, and they had no exposure to maternal smoking. They all had access to healthcare and optimal feeding practices. And the goal was to get children who would be growing in the most optimal conditions. So that would serve as a standard of what is expected in terms of growth for children with different sizes from different cultures. Next slide. So as I said, WHO growth standards that we're using in Canada are really reflective of optimal growth in children. And so usually this is what you'll see if you search for growth chart. There are some for boys, some for girls, and we all use the WHO standard. And for preterm babies, we would start at 4 weeks to 10 weeks of age. Before that, there are the Fenton growth curve, but that normally, like, the pediatrician would be able to use that. Usually, for parents, maybe it's easier to just stick to the WHO curve, but just as a reminder, they're more reliable once we start at 4 to 10 weeks of corrected age. Next slide. So, as I said, so if we just have the weight, while a single measure at one point in time is useful to screen for potential nutritional deficits. So if I see this little Tom just for one visit and I see that the weight is under the 3rd percentile, maybe this should raise some questions and for me to ask more questions to the family in terms of the nutrition, the history of the baby, and so on. And then decide upon that what to do next. Next slide. but it's more reliable to have several measures to appropriately assess growth. So if I see Tom at the first visit and see that actually he's tracking, in the follow-up visit, he is tracking along the same line, this is less of a concern than if, I see him at this point, but actually, he had already lost a couple of grams in the previous week. So it's really important, yes, to have a single measure, but if it's below the third percentile, normally there should be like several measures to really be able to track what's happening and make appropriate management. Next slide. But the weight is one thing. We also need the length to really assess growth more in depth. So if I see that here Tom is 3 kilo, but if we look at the length, we see that he's at 49 centimeters, which is also below the third percentile. So that brings me to another type of curves that people should be aware of. Next slide. And these are the curves that really takes into account weight in relation to length. So for babies under 2 years of age, we'll use those weight to length charts, which are here. But after 2 years of age, we will be using body mass index, which probably some of you are familiar. So just looking at weight on its own may not give the whole story. So it's really important to assess the weight in relation to the length. Next slide. So if I actually look at Tom here and I put his weight here for his length, I can see that actually he falls within the curves here and within the range, which suggests that he is proportional. So already this is more reassuring for me as a pediatrician. So often, as I said, like parents will look at the curve and say, hey, my kid is under the third percentile. The next thing I'll be looking at the length. And then when we realize that the baby is proportional, this is already like a step toward the right direction. Next slide. So as I said, we have the weight, the length, and the proportion here. Next slide. We can see that, what I'm trying to show here is we could have the baby here, Tom, which has exactly the same weight, right? And the weight, if we look here, is within the curve, but the Tom happens to be like really long. He measures 60 centimeters, which is right above here. And so if I plot the weight for the length, even though Tom actually looks bigger, just looking at the weight curve, he's actually below the curve when I look at the weight in relation to the length. So that's why I think it's important, even if the baby's weight is within, the curve, to look at the weight in relation of length, because otherwise we might be missing some growth problems. And if we look here, everything that falls in that area would be defined in our medical terminology as wasting. Next slide. So according to the World Health Organization, child wasting refers to a child who's too thin for his or her height and as the result of recent rapid weight loss or the failure to gain weight. Next slide. And we know that optimal nutrition and growth is necessary. Indeed, children with better nutrition will have better immune systems, which means less infections. They'll have better gastrointestinal function. They'll have better pulmonary function, and they'll also have better brain growth and development. So that's why it's really important to look at growth at every visit. Next slide. So when do we worry? So as I said, we cannot just look at a single measure. We have to look at the weight in relation of the length. So when do we start worry? Well, childhood growth faltering is defined as a child who would have the crossing of the weight downward, would have like the weight which is crossing downward 2 major percentile lines. So you can see here that the baby who's starting here, which is around the 50th percentile, and start, crossing percentile, like crossing some lines downward, that would be a source of concern. And if we look at the weight in relation of the length, we would, as I mentioned before, our growth faltering would be, we would say that there's growth faltering if the weight for length is below the expected range on the age and sex-specific growth charts, like here depicted on the right. Next slide. There's also another notion that I want to bring here. So we've been focusing on weight, but there's also stunting, which would be like a short length. So that's defined as a length or height which is less than the third percentile, and it can be the result of chronic malnutrition, in which case the weight could be proportional to the height. And I'm going to show it here if you look at the growth chart on the right side. So we can see that if we focus at the last dot, the last triangle, you can see that, the triangle for the length is at the same place as the triangle for the weight. So someone could be saying, well, probably that if I put that, the weight in relation to the length, the child is quite proportional. But if you look once again, over time, we can see that actually the weight has been crossing percentile and the length has been crossing percentile. So the story becomes a little bit more complicated, but the main point is really like we cannot just look at one point. We have to look at serial measures. We have to look at trends over time, and we have to put all the story together. Next slide. And here, as I said, I have the same weight, the same length, but the story is completely different. The baby was actually growing with the weight coming up and the length coming up. So once again, serial measures to be really able to appropriately assess growth. Next slide. So if there is growth faltering, what might be the reasons? And usually, like in medicine, we like to categorize things. So sometimes there's not enough coming in, so we have to look at the intake. It could be that the body is not able to use the calories, so then there's a problem with the absorption. Or finally, the body might be spending more energy with increased metabolism. And we know that the premature baby might be vulnerable to some of these aspects. So if we look at not enough coming in, this is usually what I see the most in the practice. And this is really related to the fact that many babies following discharge from the NICU may experience difficulties with oral motor eating skills. And actually, in studies, it's shown that up to 1/3 will have some level of difficulties, which makes intake of milk more complicated. Babies can also have esophagitis, which is the inflammation of the esophagus, which connects them out to the stomach, or severe reflux, which will really result in less actually reaching the gut. The other thing I also see often is the child who gets sick on a repeated basis, and every time the child is sick, well, he or she drinks less, which overall will decrease intake. So not enough coming in is often something that we see, and this really requires close monitoring with the pediatrician, but also with a nutritionist who can really calculate how much is coming in and whether there's a need to enrich the diet or put more calories in the milk. Other problem that we can see is the body not able to use the calories, and that will often show up with a baby who will have diarrhea. In the premature babies, or there are several causes, but if I'm maybe focusing more on the preterm baby, something we might see is severe cow's milk protein allergy, which we would then call enteropathy because the gut is not absorbing the milk well. And as I said, this would show up with more frequent stools and diarrhea. The other thing we may see is a short gut syndrome if the baby actually had surgical resection of the bowel because of neck. Finally, the other reason could be that the baby is spending more energy. That I will see with children with bronchopulmonary dysplasia, just because their work of breathing is more important. So they do spend more energy just to breathe. And the other one would be congenital heart disease. But here we're talking about septal heart defect, like a communication between the two ventricles, which has not been corrected yet. I wouldn't be talking here about patent ductus arteriosus in the NICU. It's usually other types of congenital heart disease that have not been corrected yet. And as the child grows, we can see that the child is working harder with his heart and not growing well. Next slide. Now, a few words on catch-up growth. So that's also a story that I see a lot in clinics. The baby was either small right at birth with intrauterine growth restriction, or after birth was, the weight was fine, but because of disease, actually left the NICU with extrauterine growth restriction, meaning that the weight actually fell well under the curve. So the question is, okay, so how fast should the baby catching up? What are we expecting? And the literature says that actually we can expect the catch up over a 2 or 3 year period. So if we look at on the left side, like the graph in the middle, the baby catching up over a 2 year period, that's totally fine. So we need to be patient as long as there is weight gain. And there's some research suggesting that rapid catch-up may not necessarily be optimal. If the child is gaining too much weight rapidly, there are some studies suggesting that this may increase the risk later on of cardiovascular diseases. So there's actually no advantage in having excessive weight gain in relation to length. So if we look at the graph on the right side, we can see that the baby is actually gaining good weight, but maybe too much weight too rapidly in relation to the length, which is the curve up on the top. So the goal is really catching up, but over a 2 year period, that's totally fine. Next slide. How about the genetics? Some parents will tell me, well, we're all very tall, so what should we be expecting? Well, typically, the 2 first years of life is what happened in utero. So it's really too early to predict how tall will be the child if we look at, length at 1 year of age. We are able to predict the height that the child will have later on based on parental height, but it's more reliable after the age of 2. So to estimate the potential height that the child could have, there's this formula that we can use. So we would take the mother's height plus the father's height in centimeter and divide it in 2. And usually if you have a boy, he's going to be 6.5 centimeter above, and the girl would be 6.5 centimeter below. And that's an estimated target. But to know if the baby will be reaching this target, looking at the 2 first years of life might be too early. So we have to wait a little bit more. But it is possible that because of prematurity, the baby will not necessarily reach his target or her target adult height. But it should not be either be overly low either. Next slide. Now, and I apologize. I think I should have saved my slides into a PDF format, and maybe so. I apologize if the slides look a little bit tricky here. Now that that we've talked about expected growth, I'll turn to the picky eater, and this is interesting to look at because the picky eater, it's not just for the preterm baby. Actually, if there was a study that asked mothers in general, do you think your child has a problem with eating? And actually 50% of moms would claim that they had at least one child with a feeding problem. So that would mean that about 25% of children have some issues with feeding. So what's important to distinguish is, well, what's a misperceived feeding problem from what's a mild feeding problem from a real feeding disorder that requires a more intensive intervention. Next slide. So if we look at eating behavior challenges, that includes the picky eater, the baby who will refuse food or will have a tantrum during meals, maybe because the child has anxiety around the food. So if we look at studies, it's 18% of preterm children who will experience eating behavior challenges as reported by their parents. And this is 1 times more common than what we see in term-born children. And we know that anything that has to do with eating challenges can cause more food-related parental anxiety among parents of preterm children if we compare to parents of term children. And this can lead to behaviors such as negative interaction or coercive feeding or controlled feeding, which will actually exacerbate or perpetuate the eating behaviors challenges that we see in the preterm child. So it's really important to address it as soon as there are some concerns to avoid those negative interaction and really promote more responsive feeding patterns, more positive parent-child interactions around meal. Next slide. So eating behavior challenges, when should we be concerned? So, well, if the child eats too little and that leads to growth faltering, as we have been discussing before, this should be definitely of concern. If the child eats a restricted amount of food to the point that they are concerned with nutritional deficits, for example, the child who would refuse any type of dairy products or any iron or any meat or any source of iron, that could also be like of concern. And the child who has a fear of eating, and I'll talk about it later, but which could signal something which has really been traumatic and be the first cues for anxiety. And so in the management of eating behavior challenges, it's really important to integrate both organic and behavioral perspectives. And by organic, I mean really looking at any medical conditions such as reflux, irritation to the esophagus, like esophagitis, that might be contributing to the eating behavior challenges, but also the behavior of the baby or the child in relation to food. And we have to remember that feeding is really a transaction between the baby and the parent. So we have to look at the relational challenges that may stem either from the child and or the feeder or the caregiver. And we have to incorporate the impact of parenting and feeding styles in the assessment and management of eating behavior challenges. Next slide. So what are the approach? So first, the first question we should all have is, are there any organic or behavioral red flags that require further investigations? Next slide. So the organic red flags would be anything that suggests, for example, an underlying physical problem, like dysphagia, having trouble with swallowing, any aspiration of food within the lungs, pain with feeding, any signs of vomiting and diarrhea. A child with developmental delay may be also more vulnerable for having difficulties with the oral motor skills. Children with chronic respiratory symptoms, coughing, shortness of breath while eating, that should raise some question whether there is some food going in the wrong hole, and obviously like growth faltering. And for the behavioral red flag, what we want to look at is, are those the first signs of maybe something which is more important in terms of the child behavior and development. So the child with food fixation to the extreme that they're very limited in what they can eat. Maybe this could be the first feature of autism. The child who has been exposed to forceful or persecutory feeding, and that can be really like sometimes involuntary from the parent, but that can really lead to anxiety later on. A child who would have abrupt cessation of feeding after a trigger event, or the child with anticipatory gagging. So all of those may require more intensive intervention with a behavioral specialist, for example, or an occupational therapist. Next slide. So the approach. So the first question really, as I said, is this normal or not? And the way we like to divide it is, well, looking at the child, is it a problem with limited appetite? Is it a selective intake, or is it a fear of feeding? Acknowledging that, many of these features could be happening at the same time. And on the side of the feeder, we really have to look at what's the feeding style. Is the feeder being responsive, controlling, indulgent, or neglectful? And I'll talk about this later. Next slide. So if we look at the limited appetite, actually in clinic, this is most frequently misperceived poor appetite. So I see many parents saying at 2 years, actually my child doesn't eat very much. And to the point that now I start telling them at the 1 year visit that at 2 years, they will for sure tell me that their child has poor appetite, but I will tell them why not to worry when we get there. So if we just look at the physiological reasons behind that, we can see that from 0 to 2 years, the child almost doubles in size. So what I'm showing in the figure is, so on the right, on the vertical line, it's the growth velocity. So the number of millimeter per year that the child will gain. And so we can see that in the red circle, between 0 and 2 years of age, the baby is gaining like 12 to 20 centimeter per year of length. That's a lot. But after, from 2 to 12 years, the child only gains 6 to 8 centimeter a year. So we can see that in the blue circle, the velocity, the growth velocity, or the number of centimeter per year of length gain, is much smaller. Next slide. So it's logic to think that the caloric needs are not as high as before. So before, because you're doubling in size, the baby really needs a lot of calories and has a huge appetite just to be able to grow. But afterwards, the growth is not as important. So the caloric needs are not as high. So it's normal actually to have a lower appetite. So for me, what's most important is if the child is growing, that's perfectly fine. And what we have to remember also is that the smaller child will also have a smaller appetite. So once again, as long as he or she is growing, we are very happy. So the first thing I'll show the parents is if the child has perceived poor appetite, well, maybe this is true, but first, if the growth curve, if the child is following the growth curves, this is already very reassuring. And I can say that majority of the time, this is what we'll see. And just explaining the reason behind will actually give, a physiological reason, and that's usually enough to reassure parents. So typically, what I'll say is in a typical day, the child will eat one really good meal, and usually that meal is the one that occurs at daycare with the other friends. The second meal, the baby or the child will eat maybe like, a third of the plate. And then the third meal, if the child has a carrot, we're all very happy. So that's the standard for the 2 to 5 year old. One really good meal, a second meal, which is maybe a little bit, and the third one, which is nothing. Next slide. What is more of a concern is we can have this energetic, active child with limited appetite. And this is the type of child, who just runs around, refuses to sit and eat. This child has more fun to play and prefers to talk than to eat. And that really leads to a lot of parent-child conflicts, and often those conflicts will just, exacerbate the fact that this child is not eating. And then the other type of child that we can see, but I see this type of child less often in my neonatal follow-up clinic, but that would be the epithetic withdrawn child. And this child usually has malnutrition, and we can see that both the child and caregiver appear depressed. And I'll see these type of children more in other contexts of lots of stress and maybe social deprivation. What I'm more likely to see is really that energetic, active child who prefers to play rather than to eat. And of course, the third reason would be if we suspect any underlying organic disease, which would cause limited appetite. Next slide. So what to do? So in case of misperception, I think that, what's important is parents need to accept that the parent need to accept that the child is able to recognize his or her own hunger and satiety. Next slide. So there's the concept of shared responsibility here. So what I tell parents is really it's really important to give the child some control. So the parents will control the what, the where, and the when. So that means that the parents need to decide what food the child is eating, and that, the parent needs to select. It's not the child. So this is the role of the parent. Where is the location of the meal? So the parents need to say, well, this is occurring here. You cannot decide. And, and the meal should occur at the table without distraction with other family members to make this a social event. And parents should also decide on the when, so have a routine with a specific time for the meals. Next slide. Next slide. And the child gets to decide on how much food he or she wants to eat. So if the child decides not to eat, and is growing well, that is his or her right. Next slide. And here I'm putting other, important things to remember regarding feeding, really avoiding distraction during mealtime. So that means no television, putting our cell phones away. Try to maintain a pleasant, neutral attitude throughout the meal. And this is, more easy to say than to do, but that means that if the child eats all his or her food, we should not make a party and say, woo, you're so good, this is amazing, because then there's always the risk that the child starts eating to please the parents, not because eating is a necessity. But at the same time, if the child is not finishing a plate, we should not starting to tell to the child, oh, this is awful, you should be eating, I spend so much time cooking, stuff like that. So we should really, the child eats, it's good, doesn't eat, it's also good. I mean, it's neutral, the neutral attitude. And as I said, it's easier to say than to actually do. We also want to plan the schedule of feeding to encourage the appetite. And that means that we should limit meal duration to not more than 20 to 30 minutes. Over that, it's way too long for a child's level of attention. And after 20 to 30 minutes, if the child is not eating, most likely he or she will not eat more. And usually we'll try to limit to 4 to 6 meals. That means like the 3 main meals and maybe 2 snacks over the day. And what we want to avoid is really the child who is continuously snacking or drinking milk in between the meals. So in between meals and snack, what we want is only the water. So when it's actually the meal time, the child will have some signs of hunger. Then like another rule is to introduce new foods, and I'll talk about it a little bit later. Encourage self-feeding, where it's very tempting to, take the spoon, especially in the Asian culture. I can still see my mom with the spoon and, trying to, feed more food to my kids. But this, once the child is able to self-feed, we should avoid that. And tolerate age-appropriate mess. I do hear some parents sometimes who say, well, no, I don't let my child, self-feeding because they make a mess afterwards. I think we have to be tolerant of that. Next slide. So in case of the energetic, active child, I think what's important is really to establish a routine, as I said, to encourage hunger. So that means, like I've previously shown, a maximum of 5 meals a day, including snacks, only water in between, and really make sure that the parents adhere to that schedule. You can't really, it's really hard. I mean, if we don't adhere to that schedule and change it all the time, it's difficult for the active child to really be able to feel the hunger. He really needs like this prediction, but it is possible that we need to enrich the diet before we're really able to get this child into a routine. And sometimes it does require some behavioral therapists to work with the families. Next slide. Now let's turn to the selective intake. So I'll just talk about what's normal is the neophobia. And usually I also introduce this notion at the 1-year visit, just, as so parent can anticipate that this will happen. But it's actually normal between at 18 to 24 months, which is the peak where we see that, that the child suddenly becomes suspicious of anything new, or even like stuff that he's seen before but doesn't remember, and then he sees it again and refuses to eat it. So I'll hear parents at the 18 to 24 month visit saying, hey, like my child used to eat broccoli, he or she loved it, and now like he just spit it out and throw it away. That's normal. And the danger would be to remove this food from the diet of the child. The child will really need repeated exposure, up to 8-15 times before he or she decides to eat it again. But eventually, if repeatedly exposed and also seeing people around eating the food, they will naturally restart to eat it. So that's what we call neophobia, and that's normal. Now, we could have some children who are a little bit more picky. So that's the next slide. So I do see some families who will do that repeated exposure, and still the kid tends to be a little bit more difficult, and overall will have a lower variety of foods. But as long as the child is growing and developing well with adequate energy and nutrient intake, I think we have to accept that. So usually what I do is I just look at, what type of food the child is eating, and to make sure that we have at least some foods in each of the important categories of food. And if that's the case, then, I think we have to accept that the child may be eating a lower variety of foods. It becomes a problem if the parents start to enter into coercive feeding, which means that that the parent will force the child to eat the food, which can really lead into problems later on. Or on the opposite, will be more indulgent and really accept that the child eats whatever he or she wants. And then what the problem with that is the tendency actually for the child to eat unhealthy food. So really, I think we have to accept the picky eater, and the danger really comes from the parents starting to enter in some behaviors that will make the child's behavior worse. So it's really worth being able to recognize it if we do it, to avoid later problems. And the last category would be children with sensory food aversions, and that becomes more of a concern when the child has less than 10 or 15 foods. So sometimes I'll see some children that really parents can tell me exactly like the 5 foods that this person, that the child can eat. And this may be a problem in terms of caloric intake, but also the risk for nutritional deficiencies. And it can be associated with other sensory manifestation, like a child who's sensitive to noise or touch. And we see it more commonly in autism. And that really requires intervention with occupational therapists or behavioral specialists, which will really coach the family and the child to be able to eat a little bit more foods. And often in the meantime, we do have to supplement. Next slide. So what to do? As I said before, offer foods 8 to 15 times at least. For the picky eater, actually, I've seen parents being super creative in hiding the food, like putting pureed vegetables in the spaghetti sauce, being like, experts in smoothies. And I think that's fine. And we have to accept that as long as the child is getting the nutrients. And once again, as long as the parent is deciding on the types of food that the child eats. We could also involve the child in food preparation. So I've seen that like when they get older, if they prepare the food, they're more likely to eat it. I've seen also some parents being quite amazing in designing those attractive foods, which made their child eat. And for as I said, for highly selective children, behavioral therapists or occupational therapists may be necessary really to avoid, to see improvements over time. Next slide. Now, for the fear of feeding and eating, it can be related, it's often related to a traumatic experience. So, for example, the child who had a single, who had a severe episode of choking, or the child who's repeatedly exposed to painful or unpleasant oral procedures like intubation. And we know that children born preterm have had their load of traumatic experience related to anything that goes around the mouth. And the other type of children that we can see are those who had a lack of experience because of being too fed, so they have missed some important feeding milestones. So these children can have more fear when it comes to eating just because they feel like they have a lack of control. Next slide. So what to do? Well, the pediatrician really needs to identify and resolve the source of pain, because maybe the traumatic experience is related to the pain from reflux, for example. And then it's a big work from the healthcare professionals, the parents, to be able to reassure the child. And this does take time. And sometimes if we try to go faster, we actually go backward. There might be some desensitization over the mouth and gradual non-threatening exposure to food. It's much easier when the child is able to control the food and eat on his or her own, because there's this sense of control. For older children, positive reinforcement with rewards are things that have been recommended. And as I said, we really need a multidisciplinary team, and supplements like liquid oral supplements might be necessary while we get the child to be fully fed orally. It takes time, but majority of the time there is improvement which is seen if we've been patient enough. Next slide. Now, a few words on feeding style. So really what we want to promote is responsive feeding. So what is responsive feeding? Next slide. So as I've mentioned again before, it's this notion of shared responsibility. So parents has the responsibility on the what, the where, and the when, and the child has the responsibility on the how much. What we really want to foster is really guiding the child's eating as opposed to control it. We want to arrange a schedule to induce appetite, as I've said before, and we really want to avoid coercive techniques. And we've all done it before. As I said, we've all said, like, if you eat your broccoli, you will have your dessert, or please eat 2 or 3 more bites so mommy will be happy. I mean, we do it. And we all do it as long as we recognize it and try not to do it too often. That's the goal. So this is what we want to promote, really accept that shared responsibility, really to let go on some of the control that we may have as parents. Next slide. So these are the 4 types of feeding styles. So we've talked about the responsive feeding. The coercive authoritarian feeding would be the parents, who say, well, it's like this because I said so. And that includes bribing and forcing the child to eat. And what that leads to is the child not being able to recognize anymore his or her satiety. Or at the same time, if the child is restricted on some foods, never get to eat fun food like chocolate, for example, sometimes the fact to be always restricted may lead to the opposite, with the child actually hiding to eat. So it's really important to let the child recognize his or her hunger as well as his or her satiety. The indulgent feeding style is, the parents who will say that, well, or the grandparents who will say that he or she went through so much, so the child can basically do whatever he or she wants. And it's very interesting because, I think this tendency of overprotection is very understandable after having been through the NICU. But at some point, it may become tricky as the child starts, controlling everything. And most of the time, parents will recognize it and will say, well, I think I've kind of lost control, so I have to regain that control. So so, like the indulgent feeding style is, I will make you something else to eat. And so usually the parents have 3 different meals, one for them, one for the kid number 1, one for the kid number 2. So it's almost like a restaurant. And the kid will also be like the all-day snacker. So that, I'll see that the child is actually drinking many bottles of milk, but never eating the food. And that really takes some discipline. And I try to reassure parents that at this stage, the child does not have any attachment issue, and it's okay to say no. But it's really a work from the parents, and we have to expect no tantrum from the child. But over the long term, this is really important, just so the child can have actually better nutrition overall. And for the neglectful feeding, I actually don't really see that much in neonatal follow-up clinic. It will be more in situation of social deprivation. Next slide. So my key messages. So expected growth in infant and children, it's really important to use corrected age until 2 or 3 years. As I've mentioned several times, several measures are necessary to assess growth. Weight and length need to be considered together. If there is growth faltering, it really needs to be investigated and closely followed. And in terms of catch-up growth for children who had growth restriction either in utero or postnatally in the NICU, we can expect this catch-up to occur over a 2 or 3 year period. Next slide. And as for the picky eater, expect that after 18 to 24 months compared to before, the child will have lower appetite and will tend to become more picky. And it's really important to promote responsive feeding. That means shared responsibility between the parents and the child, and guiding the child's eating. That can be with modeling, showing pleasure ourselves when we're eating, etc. And I think that's about it. And I'll be taking questions now.
Thank you so much for your presentation. There was so many practical things in there that I think, is very valuable for families. I loved that you talked about the 8 to 15 times repeated exposure. Like when I think of the foods that I introduce to my kids, you're like, you feel good if you try 3 times, and then you're like, oh no, they're really, but 8 to 15 times is a commitment to those new foods.
Yeah, and usually what I tell parents is, if you, I'll take the broccoli example, and if you know that your child doesn't like broccoli, don't put a plate full of broccoli, but maybe just one piece. And it's this repeated exposure, and eventually one day he'll grab the broccoli and eat it, and you'll be like, yay, it finally happened. But it's really to have this repeated exposure, so the child doesn't start forgetting about broccoli and not eating it at all.
The other thing I noticed is that a lot of people from our audience are from all over the world. And that just underlines to me that this isn't just a North American problem, that kids everywhere maybe have feeding and eating difficulties and challenges.
Yeah. And I mean, like, I can talk about the Asian culture where, we just, it's, feeding is so important. And I'm sure it's the same in other culture, but who doesn't remember seeing, their own parents, running after their kids to feed that extra spoon. And I can understand why we do it, because eating, growing is so important. But at some point, we just have to realize that these behaviors that we do as parents, that we think are for the good of the child, might lead to other problems. At least if we can recognize them, it's already a good first step.
Mm-hmm. I don't know if you have done any study into this, or maybe just anecdotally you've noticed a trend, but is there any kind of attachment with the breastfeeding babies who come out of NICU? Is their feeding after NICU, when they get into solid foods, different than those who weren't breastfed in NICU?
I'm not sure. Actually, I think it's more with the sleep. for the breastfeeder, because the child who's being breastfed requires more frequent breastfeeding. So to be able to achieve, to be able to sleep all through the night is something more complicated to install. But actually, no, I think the key message is that there's this window of opportunity for introducing the solid food between 6 to 9 months of corrected age. So often, because breastfeeding is enough from 0 to 6 months, the baby who's breastfed may have later introduction of the solid food, as opposed to the bottle-fed baby, that where parents will tend to introduce the solid food more at 4 months. So they have from 4 months to 9 months to introduce the solid food. So, I think it's just a matter as when you start the puree, if the child is taking the puree, to rapidly progress to more textured food. So by 9 months, the child is actually eating pieces like, soft avocado, soft banana. And I think the tricky part is if you're exclusively breastfed for the 6 first month, you just have 3 months to be able to go from the puree to the the solid piece. Now, some parents have been asking me about self-feeding. So I don't know what's the term in English, but for babies born at term, the more we see is at 6 months, the baby already starts chewing pieces of foods. For example, parents will put like grapes in a special thing, and the child just chew the food. So then they're introduced first, like they chew the water of the fruit, for example, but then they rapidly gets to the pieces. And I've asked the occupational therapist what they thought about this, way of feeding, which is really introducing the solid food faster. And they always recommend that we be a little bit more careful with premature babies, just because we know that they may have some more challenges with oromotor skills. So they actually did not recommend for now, like going directly from the solid, the chewing the banana, but maybe start really with the puree, but progress rapidly if the child is tolerating well. And at least not do it before 6 months of corrected age. I've seen parents at 4 months with term babies already starting with the pieces, but there are no studies with the premature baby to say it's safe, but we don't want to push our luck too much either.
That's a very good point, because it is one of those trends that you hear people are doing. And again, premature babies, they develop differently. And so we can't always just follow what term babies are doing.
Yeah, exactly.
My other question was, can you determine, so do you see babies who go home high on the growth chart when they leave NICU and then not do well once they're home? Or can you typically kind of predict based on their growth chart before they leave how they will do?
Well, one point, actually, some children, I think, leave the NICU a little bit too big. So the ratio of the weight for the length is actually very disproportional, the child being like way too big. So I will see some slowing of the weight gain, and then the child becomes more proportional. So as I said, what's important is the child needs to gain weight, not lose any weight. But I can see sometimes some thinning, and sometimes parents will get concerned because they'll see that the weight gain velocity is not as high. But maybe it's okay at this stage because the child is just getting more proportional as long as there is some weight gain. Actually, the child who starts really small may have more difficulty in gaining the weight. So this child really usually has follow-up with both a nutritionist and an occupational therapist that really will assess the skills. Because, if they were small up in discharge from the NICU, it's very possible that they had some issues with the oromotor skills and have more trouble having good intake.
Mm-hmm. We have a question here from Tasmin, who said, if picky eating occurs when they're toddlers, will it continue or will the child outgrow it?
Well, the child will, it really depends. As I said, there are several levels of picky eaters. Some are normal picky eater who will just outgrow it. So they do have a period where everything new will be suspicious, and usually at 3 years, they'll become more open to any types of food. And some children might be a little bit more picky. Often when we ask the parents were also picky eaters themselves, so maybe it has nothing to do with prematurity. But for these children, as I said, it's important to continue the exposure. So the problem will be really if the parents enter in a pattern of behavior that limit this exposure to food or force the child to eat the food. So, if we avoid that, I think the child will maybe not outgrow. It's possible that, they're always a little bit picky. Adults can also be picky. But as long as, they don't enter into a nutritional deficit, and I would say that the majority of children who are picky eater, when you do a detailed history, they still have, a sufficient variety of food for adequate growth and adequate nutrients.
We have a question from Helen as well that I think goes along with the question I was thinking of, is when parents are feeling concerned. And so Helen asked, is there somewhere we can find a weight to length chart?
Yeah, so these are available. Those are all available from the WHO. So I think if you just Google WHO weight to length growth chart or something like that, you will find them. They are actually on the same page as the head circumference curves. So it's easy to find just by Googling them. They're publicly available.
And for those who are concerned, what advice do you have? Sometimes you wait a while for your next follow-up appointment. I know here in Nova Scotia, and I think it's elsewhere in Canada as well, there's people having problems finding a family doctor. So if someone's feeling worried about their child's intake and their growth and their weight, what is your advice for them?
For a small baby, I think it's worth going to a walk-in clinic. Growth is so important. And if, in that walk-in clinic, they tell you your child is just fine, that's already reassuring. But we don't want to be missing this child who was this was the first sign of something going wrong. Nurses are able also to look, to put the child on a growth chart and also look at serial measures. So, at least if there's a nurse who's able to look into that with a nutritionist, it might be a first, good step. The physician is also super important, but at least if we can get the nutritionist and the nurse first, that would be great.
Mm-hmm. Well, thank you so much again for covering this topic for us today. I have to say, when you talked about shared responsibility, I just was like, so much of, parenting, it's such a respectful and honoring way to approach that relationship of parent to child. And so I appreciate that perspective and that advice so much. So thank you for sharing your wisdom and your knowledge on this very important topic today.
Well, it's my pleasure. And people can reach to me. They have my email address.
Thanks again. And thank you, everyone, for joining us for today's episode of Preemie Chats. A special thank you to AstraZeneca for their ongoing support of educational programs such as this one. And just a reminder that if you missed a part of today's session, or if you want to rewatch it, then you can head on over again to the website at CanadianPreemies.org. And there you will also see over 300 episodes of Preemie Chats covering a variety of topics. So you can watch all those past ones as well. You'll find many, as I mentioned, free resources for both healthcare professionals and families on prematurity in and after NICU. There's lots of support options available there. And you'll also be reminded the Canadian Premature Babies Foundation is a charitable organization. They offer so much for free, and they depend on support to continue this important work. So while you're there, think about how you can support CPBF's mission to empower families of premature babies in every step of their journey. That might be sharing your story, your wisdom, might be connecting into communities, and might be giving what you can to help CPBF carry on its mission. Together, we can create a brighter future for all NICU and preemie families. I want you to join us here next Friday, also 1 p.m. Eastern Time, for a story that is very inspiring. It's about a family whose premature triplets were born during the COVID-19 pandemic and out of difficult circumstances. This family established an amazing campaign to help families of premature babies in their region. You won't want to miss it, so tune in next Friday. In the meantime, I hope you have a great weekend, and we have Canada Day on Monday. So if you're in Canada and celebrating, happy Canada Day. Thanks for watching.